So this patient, I'll show you the CT, and it's a stomach lesion. And I can tell you, like, I was looking at the PET-CT, but in retrospect, I would have never called it. Do you guys see anything?
I think we saw the name of the, of the thing, but
Yeah.
yeah, I never would have called something on this. And then stomach distension is always really tricky because they could have just eaten.
Right.
Yeah.
Yeah, I mean, the outside report says something about, you know, Bezor and but yeah, it was an imaging study that was done outside. They called it a Bezor, and so then they went in to like remove it endoscopically, and then they found the lesion.
Mm.
And the lesion,
with gastric lesions, I assume it's like right there, the pylorus thickening.
yeah.
But one tiny clue is like if you see any lymph nodes next to the stomach, I always then look at the stomach more carefully.
Huh. Let's see.
We have a gastric protocol, but that's kind of if you already know that they have something wrong with their stomach. So they basically like chug volumen right before the scan, so it distends the stomach nicely, and then you can actually really nicely see most tumors. But pylorus is still going to be tricky, especially if they don't have any lymph nodes to like secondary signs.
Yeah.
And you know, it's I find the pylorus really challenging actually, because it's sometimes is it thickened, is it abnormal, or is it normal? You know, it's just. I'm just not as confident about it.
I don't think you can be too accurate about it.
So this was very humbling, because this is what the PET looked like. So that was a pylorus gastric cancer that was confirmed by histology, and there's no like distant mets. But I thought this was really interesting. Because I'm learning more about PET now, I started reading PET. But stomach cancer, I didn't realize is the leading cause of cancer death in the world. Typically, PET is not helpful for staging, T-staging. It's usually done by EUS or CT. But what PET is used for is lymph node metastases. So there's the AJCC, there's a new staging. Before it was based on like location, but now it's based on number of positive lymph nodes. That makes it N1, N2, and N3. So N1 is positive 1 to 2 lymph nodes, N2 is like 3 to 5, I think, and then N3, N4. The interesting thing is PET is helpful for identifying like compartment 3 and compartment 4 lymph nodes, which become M1. So even though they're lymph node mets, they're considered M1 and they're no longer resectable. And so those are the ones that are highlighted in pink. PET is also helpful because it can be used to assess tumor response. So if you have a 30% drop in FDG activity after chemotherapy, then they have their response rate is like in upwards of 85%. Similarly, if the primary tumor, if it doesn't take up FDG, which is common because it has a lot of mucinous component, then it's a poor prognosticator of outcomes. What else? So metastasis. So here, this is a portohepatis lymph node. This becomes M1, even though it's a lymph node. And so now they're no longer surgical candidate. So similar to ovarian mets, gastric cancer can also sort of spread through the peritoneal dissemination, which is a poor prognosticator. That's basically it.
Yeah, Nelly, that picture, go back one slide. That's really important, those nodes. I didn't really realize how, like, you know, because sometimes it can be actually pretty close to the stomach, like that SMA node and stuff like that, if it's like a pyloric tumor. But yeah, it's really important to describe those. And then any retroperitoneal node, like below the level of the renal veins, is also like distant metastatic disease. So if you're suspicious about any of those, that's where like a PET can be helpful to kind of confirm that they're active.